Now that you already learned how to perform liver sonography, we want to take you more and more into the clinical field to show you how ultrasound can help us to detect pathologies. In this basic course, we will introduce to you the most common liver diseases you may encounter in everyday routine of abdominal ultrasound. We split this topic into two chapters: diffuse diseases and focal lesions. We are going to start with the chapter of diffuse liver diseases. We will discuss liver congestion, hepatic steatosis, and liver cirrhosis. Let's talk about liver congestion first. What could be the mechanism of this condition? Hepatic venous outflow is impaired, there's elevated hepatic venous pressure and decrease in hepatic venous flow. The hepatic veins are widened and the liver is enlarged because of the congestion and the stasis of blood. There's hindrance of venous outflow. And the possible causes for this status? In most of the cases, it's congestive right heart failure or even global heart failure. But also some chronic lung diseases like COPD or emphysema can lead to elevated pulmonary pressure and over time to right heart failure. Large pulmonary embolism can cause acute right heart failure because of rapid elevation of pulmonary pressure. And a more rare cause, constrictive pericarditis, can lead to impairment of right heart function and to liver congestion. Most of our patients with liver congestion show up with clinical symptoms of right heart failure like dyspnea, edema of legs, and signs of pleural effusion. Rarely the patients feel some mild discomfort in the right upper abdomen because of tension of liver capsule. In blood results, elevation of liver enzymes can occur. Now, let's talk about what liver congestion looks like in our ultrasound pictures. In this picture over here, you can easily see that the liver veins over here are widened and also the confluences of the liver veins is widened too. And here also you can detect some small dark area which is free fluid. That means the patient has ascites too. The same in this area over here on our right side of the picture, even a little larger field of free fluid, which points to ascites. In this picture over here, again, we see the widened confluences of the liver veins, very easily seen. And now we got a video clip for you. It's the liver over here. Again, the widened confluences and liver veins. And here, in this area, dorsal, we can see some free fluid too. But this time, this is pleural effusion. This is cranial of the liver, and it points to pleural effusion. The same in this video over here, and you can also see the heart pumping. But we can't take a glimpse of heart function now because this is a plane of the liver and we could not possibly judge the right heart function over here. But again, the widened confluences of the liver veins, plump liver veins too, and these pleural effusion. This is another plane here now. It's a longitudinal plane now. And this time we've got the liver over here. Sorry. Let's get back a little bit now. In this video, this is the liver in a longitudinal plane. We can see the diaphragm over here. And cranial of the diaphragm, we can see this area of free fluid, which is pleural effusion. Now, let's sum up. What have we seen in these pictures? Liver congestion in ultrasound shows up with enlarged liver with rounding of the inferior border. No acute angled edge, but a more obtuse angle of the inferior rim of the left liver lobe. We've got reduced echogenicity and quite dilated, clumsy liver veins. Of course, we got a wide hepatocaval confluence, and quite frequently we will see pleural effusion and sometimes also ascites, as we've seen in our pictures over here. The next pathology we want to discuss with you is the fatty liver. Fatty liver disease is something we encounter quite often in ultrasound examination. It affects approximately over 30% of general Western population. This is an abnormal retention of fat in liver cells, and it occurs because of abnormal retention of lipids. One type is the non-alcoholic fatty liver, which occurs most in patients with metabolic syndrome, diabetes, obesity, and dyslipidemia. Non-alcoholic hepatic steatosis is the first stadium of non-alcoholic fatty liver disease. Its prevalence is between 20 to 30% in Western population. And it can also proceed to steatohepatitis, fibrosis, and finally even cirrhosis of the liver. Other factors like drugs or metabolic storage diseases may also lead to fatty liver disease. But the second most common reason is alcohol, which can lead to alcoholic fatty liver. We know that steatosis is common in heavy drinkers, but it is also seen in up to 40% of persons with so-called modest alcohol intake. Now, let's see what steatosis looks like in ultrasound. What would you think of this picture? We remember that in our ultrasound assessments of the liver, one of the main points is the reflexibility of the liver parenchyma, and we compare it to the kidneys. So let's do this here. Okay, I try to stop this video at the right place, over here. Now let's take a look at the liver. It's the right liver lobe over here, and in the neighborhood we got the kidney. So when we look at the kidney over here, at the renal parenchyma, it's a lot darker than the liver over here. You see the liver is quite bright, is hyperechoic, there's more reflexibility, a lot more than the renal cortex. This is the first and a very important sign for hepatic steatosis. And it also seems a little bit enlarged, the border is rounded. And this is also a sign, because a steatotic liver is enlarged too. Over here again, we got the liver, which is very bright, with a high reflexibility, high echogenicity. We got the gallbladder over here. And I want to show you a special area here near the gallbladder. As you can see, this is a nearly map-shaped, slightly hypoechoic area. It seems hypoechoic compared to the high reflexibility of the liver over here. And this is a so-called focal hypoechoic area. This is seen quite frequently in steatosis, and these are areas that have a nearly to normal fat content. And that is, let's say, these areas have got normal reflexibility, and the rest of the liver has, because of ingestion of fat, because of the fat content, has a higher reflexibility. And these areas, these focal hypoechoic areas, are most frequently seen near the gallbladder or ventral of the portal vein. Let's have this video again. Here, near the gallbladder, this focal hypoechoic area. In this video, again, we can compare the liver parenchyma to the kidney over here, to the cortex of the kidney. We see the high reflexibility and also something else. We can see the liver is quite enlarged because it reaches caudal of the lower pole of the kidney. You see the kidney here in the longitudinal plane. And the liver has to be enlarged because it's a lot more caudal here than the lower pole of the right kidney. One more time. Here we got a small object over here. What would you think? You're right, this is a gallstone. Another steatotic liver. You can see sometimes the fat content of the liver differs a little bit in different areas. This can also occur in steatosis. Now, let's sum up the ultrasound features of hepatic steatosis. We've seen an increased reflexibility. Fat and fatty tissue in liver ultrasound has a high echogenicity, and especially in comparison with the kidney, the liver looks a lot brighter than normal. The organ is also enlarged with somehow rounded borders, not the normal acute angle at the inferior border. And we quite frequently can find the so-called focal hypoechoic areas. We remember, typically near the gallbladder or the portal vein, somehow map-shaped areas of reduced echogenicity, but only in comparison to the brighter parenchyma of fatty liver. These areas have a near to normal fat content. That's the reason why these areas appear darker than the rest of the steatotic liver. At the beginning, it can be difficult to distinguish focal hypoechoic areas from other liver lesions, especially suspicious lesions. What can help with this decision is the typical location, ventral of the portal vein and in direct neighborhood to the gallbladder. And also the typically map-like shape, appearing elongated and not round or oval-shaped like liver lesions. But in cases when we are not sure if an area like this is a focal hypoechoic area, or if a patient has risk factors, for example, a malignant disease anywhere in his body, then we should use a contrast-enhanced method. We could use, for example, contrast-enhanced ultrasound to make sure not to overlook any malignancy. At the beginning of my ultrasound career, we did a lot of contrast-enhanced ultrasound examinations because I picked out so many focal hypoechoic areas. And I was not totally sure about them. You know, I'm rather the cautious type of examiner. But with experience, I got a better eye for the features of focal hypoechoic areas. Still, when I have any doubts, a contrast-enhanced method will be performed.